Our next speaker is Dr. Ware Branch. He is a professor of obstetrics and gynecology at the University of Utah Health. He's also the medical director of Women and Newborns Clinical Program and Intermountain Healthcare. And he will be talking about some of the experimental evidence as well as clinical data on the role of complement activation in antiphospholipid antibody syndrome.
Right.
Thank you, Dr. Branch.
You bet. Here are my disclosures, and you'll understand a little bit about why. So I'm pleased to try to present the notion that inflammation mediated by complement activity plays a role in this condition. I thought I'd start by reviewing the criteria for the diagnosis, which many of you hematologists get to tangle with every once in a while during the course of a year. So the clinical features of antiphospholipid syndrome include a thrombosis on the venous or arterial side, or the obstetric criteria, which we'll go over in some detail here in a moment. And very importantly, patients are supposed to be repeatedly positive for one of the three germane accepted antiphospholipid antibodies, and so lupus anticoagulant, anticardiolipin, IgG or M, or anti-beta-2 glycoprotein 1, IgG or M. That is positive on 2 occasions, 12 weeks apart. The obstetric criteria, kind of the subject of much of what I'm going to say today, include early pregnancy morbidity, defined as 3 or more consecutive pre-embryonic or embryonic losses. I call those recurrent early miscarriages. This may be the most common reason you are asked to see a patient. I'm guessing, but it might be the most common reason, a patient with miscarriages. And then mid to late pregnancy morbidities, which include the death of the fetus in utero after 10 weeks gestation, at or beyond 10 weeks gestation, or 1 or more deliveries less than 34 weeks gestation for preeclampsia or placental insufficiency. That is, for preeclampsia severe enough or placental insufficiency severe enough to cause one of us to step in and do the delivery, iatrogenic early delivery for those conditions. In the early days of this syndrome, everyone thought it was a thrombotic problem because, of course, there are patients identified with thrombotic antiphospholipid syndrome. They present with a DVT or a stroke. And then on the obstetric side, it therefore must be that this is a thrombotic problem. But the evidence really weighs against it being primarily a thrombotic problem, and in my opinion, really always has, but there's now evidence that it is, at least primarily speaking, an inflammatory, perhaps complement-mediated condition, which is in turn associated with thrombosis rather than the other way around. Much of what I'm going to talk about comes from murine models of antiphospholipid syndrome. And this particular murine model is a passive immunization model that's popular in several labs around the world. And the pregnant mice are injected with polyclonal or monoclonal antiphospholipid antibodies or control antibodies. And then the outcome of the pregnancy is looked at usually on day 15. And what's amusing about this particular slide is that it reminds me that the first publication of this model was from us at the University of Utah in 1980-something, a long time ago. We weren't smart enough, like some of the people that have spoken today, we weren't smart enough to take this to a level of understanding inflammation in this realm, but we did describe the original model. We can talk about the sanctity, the efficiency of the model and some other factors offline. At any rate, in the hands of most people using the murine model, you give them the polyclonal or monoclonal antiphospholipid antibodies, dissect the uteri out on day 15, and you find that in the control uterine horns shown on the top, there are normal live fetuses, and they are of normal size. But in polyclonal immunization, patient number 1 or patient number 2, shown the second 2 uteri down, there are either fetal resorptions, fetal deaths, or fetuses that are present and small for gestational age, even if they are no longer alive. And so it appears that the autoantibodies will cause a pregnancy morbidity that looks like the second half of pregnancy morbidity that we see in clinical practice, that is fetal loss or growth restriction as a manifestation of placental insufficiency. The antibody. So now I want to talk a little bit about some more recent findings regarding the antibodies themselves and what they are directed against, and hence this slide showing the beta-2 glycoprotein 1. This ubiquitous glycoprotein is found in the circulation. It's found expressed or bound to cells throughout the body and is known to play roles in coagulation, fibrinolysis, probably certain platelet functions, and a number of apoptosis and a number of other activities. People working in Australia and Japan have ferreted out that the oxidized form of beta-2 glycoprotein 1 is immunogenic, and in susceptible individuals promotes an immune response that very likely includes autoantibody production, and autoantibody production of the pertinent antiphospholipid antibodies that in turn are pathologic with regard to pregnancy and thrombosis. This oxidized form is found at increased circulating levels in people with antiphospholipid syndrome compared to the free thiol or reduced form of this particular ubiquitous glycoprotein. The glycoprotein in its numerous actions exists in several sort of conformations. In the upper right-hand part of the slide, you see the circulating conformation of beta-2 glycoprotein 1. And in that conformation, domain 1, the site where the pertinent antiphospholipid autoantibodies are now thought to bind, domain 1 is cryptic to the immune system in that circular form, and so not favoring an immune response in that form. Among other things, this glycoprotein unfolds onto injured cell membranes, as shown on the bottom of the slide there, and transitions through an S phase and into this fishhook set phase on the far right-hand side of the slide. And in that form, exposes domain 1. And if the predominant or a meaningful proportion of glycoprotein 1 thus exposed is oxidized, the pertinent autoantibody is now thought to bind to that domain 1 and result in an inflammatory response. The phospholipid bilayer there could be in the venous circulation, the arterial circulation, at the maternal-fetal interface. The placenta is a very big-time producer of beta-2 glycoprotein 1. And so this is now how people are conceiving of the pathophysiology working in most, if not all, cases of true antiphospholipid syndrome. In the audience, you should be wondering, well, why don't we have just a basic anti-domain 1 assay, and we can quit fooling around with complicated clotting assays, and we can quit fooling around with these non-specific immunoassays. And I don't have the answer. I was hoping someone in the room had the answer to that. People are working on building an appropriate domain high specificity assay. So it's now thought, and we're going to show a little evidence, that the pertinent autoantibodies bind to structures associated with the cells, probably by way of beta-2 glycoprotein 1, as I have suggested. The antibodies might bind to other moieties on cell membranes. There's some evidence for that. And may influence cell function in other ways. But it is felt by most experts who worry about this that the primary event for us here is binding to domain 1 of the GP of beta-2. as beta 2 is associated with a cell membrane function. In that setting, we might have activation of the classical complement cascade. And this slide is just to remind you to say that in the passive immunization model, you can show staining for complement in the pregnancy tissues of the murine model that are damaged. That's upper panel A there versus for control IgG panel B. Another feature, and this is very important, is leukocyte infiltration into those pregnancy tissues so that we have complement activation and we have amplification loops and the calling of leukocytes to come here and help us do some damage. And that's what's going on, we think, in this model and in humans, and we'll look at a little evidence to that effect. Dr. Jane Salmon, with whom I work closely, and some others have been leading the pack in showing that blocking C3 will in turn block cellular infiltration and pregnancy morbidity in murine models. And there's evidence to support that in the pinch thrombosis model as well. And blocking C5 will rescue pregnancies, prevent leukocyte infiltration, and so on. And using C5A receptor blocking techniques will do the same thing. And so you can get at rescuing the murine model pregnancy in various ways. So as of right now, we know that murine models of pregnancy complications induced by antiphospholipid antibodies implicate the complement activation as an essential and causative factor in fetal loss, fetal death, fetal resorption, and growth restriction. Based on evidence produced by a number of labs, blockade of alternative pathway rescues fetal death and prevents growth restriction in the passive immunization model. This doesn't want to go forward. There. Let me just make sure, yeah. We were interested, for reasons I'll explain, in C5a receptor actions, particularly because of leukocyte infiltration into the pregnancy tissues. And Salmon and I and others wondered, Salmon wondered more intelligently than I did, by the way. She's a complement biologist and physician. Wondered whether C5a receptor activity, say, on endothelial cells or polymorphonuclear PMNs down there, what that activation might do. And of course, it influences cell production of angiogenic factors, and in our interest, TNF-alpha, among other active cytokines. I want to get back to a point just to reiterate something I said earlier. This is a bar graph telling you repeating what I've already said. The black bar is controlled passive immunization in the murine model, and the, what color is that, Andy? Tan bars, beige bars, thank you. The beige bars are fetal resorptions in those given polyclonal serum 1, 2, 3, and a monoclonal antibody, all right? It turns out that if you give Hirudin or Fondaparinux to animals as a treatment paradigm, a treatment management scheme, you don't salvage fetal loss or growth restriction. If you give heparin, you do. How come? I'm told by people better informed than I am that heparin has something of an effect on inhibiting C3 or C3 convertase, and that might be the action by which we see some improvement, if not somewhat robust improvement, in some cases of antiphospholipid syndrome so treated. So here we are, thinking that however these autoantibodies binding to domain 1 of beta-2 glycoprotein 1 activate complement cascade. We have effects on the effects at the maternal-fetal interface that include, likely include, I should say, disruption of cellular function, but certainly calling in infiltration of myeloid cells and subsequent fetal loss and growth restriction. We think this happens relatively early in pregnancy when the placenta is trying to form its vasculature, its blood flow, the blood flow which will presumably serve the pregnancy not just at 10 weeks or 15 weeks, but at 25 weeks and at 30 weeks with the growing conceptus and needs of the baby. We also know that in people who don't have antiphospholipid syndrome, you can invoke a role for complement activation. Someone in this room here, Jason, today has spoken much more intelligently about that than I will. It is true, though, that you can look for complement staining in placentas from patients who have lupus but not antiphospholipid syndrome and in women with preeclampsia. That science is not rich and deep, but it's out there. You can find activation of alternative complement pathway demonstrated by increased levels of BB in non-autoimmune disease patients destined to develop preeclampsia. And then, as was discussed earlier, there are complement regulatory protein mutations which appear to predispose to preeclampsia. So we went to look at whether this could be confirmed in human work by way of our PROMISSE study. This was a prospective, multi-center observational study that a group of us did, and we wanted to try to identify markers that would predict poor pregnancy outcome in people that had lupus or antiphospholipid syndrome. And this was a community pretty rich with rheumatologists and a couple of token maternal-fetal medicine people. We weren't trying in any way to influence the treatment of the patients. So the patients got whatever their doctors wanted them to get. We just enrolled them early on. We enrolled them at about 12 weeks, sometimes 15 weeks. So we didn't look at miscarriages, guys. We weren't looking at miscarriages. We were just looking at later pregnancy events. And we wanted to get people that had lupus and antiphospholipid antibodies, who had lupus without antiphospholipid antibodies, no lupus, did have antiphospholipid antibodies, or some controls. All the controls were from Utah and were so benign as to be embarrassing. So, I mean, they didn't have any adverse pregnancy outcomes. Anyway, that's the population of people we prospectively observed, speaking to them during the pregnancy in real time. One of the questions to ask and answer is, do elevated levels of complement activation predict poor pregnancy outcomes in people with lupus or with antiphospholipid antibodies? So here are data regarding BB, and the red line at the top is mean BB levels in patients that had either lupus or antiphospholipid antibodies and went on to have adverse pregnancy outcomes, including, and we had definitions for this as a part of our grant, fetal demise, a fetal death, otherwise unexplained fetal death, preeclampsia, placental insufficiency requiring early delivery, and so forth. The blue line is lupus patients with or without antiphospholipid antibodies and no adverse pregnancy outcomes, and then the healthy controls who were remarkably healthy are shown there in the green. And by 12 to 15 weeks, left-hand side of the slide, second bullet points over, you could see a statistical difference in BB. Same thing is true of soluble C5 B through 9. Although I'm told by statisticians this was less impressive, though significant. So we concluded that in lupus patients and antiphospholipid positive patients, elevated levels of B, and to a lesser extent that soluble C5 B through 9, detectable at 12 to 15 weeks, are independently associated with adverse pregnancy outcomes of the sort that we think about in antiphospholipid syndrome. So the findings support the concept that activation of complement, particularly the alternative complement pathway, contributes to these adverse pregnancy outcomes. Activation early in pregnancy. This provided us with the rationale to work on some other funding. We wanted to look at things we might block or treat or manage better that were downstream events that would then in turn we hope prevent adverse pregnancy outcomes in high-risk patients. So it turns out that in the animal model we knew that TNF was an essential and causative factor in fetal loss and growth restriction, and the treatment with these TNF antibodies, which were available in the early days of the animal models. This goes back to 2003, 4, 5. We knew that that would abrogate or rescue the pregnancies. We knew that TNF alpha deficient mice were protected in the passive immunization model, and we knew that TNF alpha blockade would attenuate the losses. So we thought that would be something of an idea. We also, one of the people working at Cornell was interested in this particular mouse model, which is a preeclampsia syndrome mouse model. And mind you, I know nothing about this model to speak of, except that you see that it has dark fur as opposed to white fur. That's what I recognize as a difference right here. But this particular non-autoimmune mouse, if I may sell it as such, gets hypertension, proteinuria, placental dysfunction, and so forth. And if you block TNF in that animal model, they do a lot better. Dr. Berman the Sherry Gilbert published that, who's an MFM, by the way, Andy. Yeah, so there you go. So we thought, well, that gives us a little more oomph to be looking at TNF blockade in our approach to high-risk antiphospholipid syndrome patients. I want to back up for a minute and make mention of the fact that it is relatively straightforward to identify antiphospholipid cases that are at pretty high risk for adverse pregnancy outcomes, including fetal death and preeclampsia, placental insufficiency. And the bottom line is a pretty simple one, and many of you in the audience are well aware of this. Repeatedly positive for lupus anticoagulant in a decent lab, that's a bad problem. That patient's going to have trouble. Or triple positive, which means they're also repeatedly positive for lupus anticoagulant in a lab, right? Those patients in the observational study have about a 40% likelihood of having an adverse pregnancy outcome of the sort that we were looking to explore, find out about in the PROMISSE study. 40%, and that's on heparin and aspirin. Well, you know, that makes me think heparin and aspirin is not a very good treatment. So that's why we went looking for something else to do based on work that several people had done in labs. And so this is our study. We're going to look at certolizumab, a TNF blocker. We are looking at it. And we liked choosing certolizumab because it's a pegylated TNF blocker that doesn't have an Fc arm and is not transported across the placenta, at least actively. So that made a little bit of sense to us. And so we have this trial going to determine whether TNF alpha blockade added to a regimen of heparin and low-dose aspirin, as is standard treatment, reduces the rate of adverse pregnancy outcomes in women who have antiphospholipid syndrome by the definition, and they have a persistently positive lupus anticoagulant. And we would love to hear from anyone who has a patient like that so that I can talk to them. We consider this sort of a rare disease study. The IRB is in Utah, so enrollment and consenting is in Utah under our IRB. All patients get standard treatment with a heparin product and low-dose aspirin, and then all patients get the anti-TNF agent. We have to enroll them early because it's our hypothesis that early treatment, when the placenta is vascularizing, so to speak, is critical. The comparison group is the PROMISSE patients that we collected over some 8 or 10 years. emphasizing the importance of really well done registries to form control groups of infrequently rare diseases and things that don't happen a lot. So one of the things we should all be doing better is putting together some accumulation of these infrequent patients in a really pristine form so that when you introduce a new thing, you can look back at the same sort of data set in your registry or observational group. So that's how we designed it, thinking we were being kind of clever, I guess.